actually you're going to get a worse maternal mortality. So there is a real concern that this might in theory be the right solution, but in practice it might do more harm than good. And we know from previous experience in certain communities that there are risks for this. The Inuit in northern Canada, the Eskimo population in northern Canada, were for a long time flown from their tribal lands into Canada to have their babies. And they fought very, very hard not to do that. And there's been a real reversal of this policy now in Canada. And I wish I had the quote. There's a fantastic quote that's quite often used from one of the Inuit leaders who basically says, when women give birth in the community, it brings meaning to the community. When the women are taken away, the community loses its meaning. Without meaning, there is no life. So they have accepted the risk, and there is an additional risk of birthing out of the mainland, in their own communities, because they see the benefit of that to their spiritual well-being as a whole community, which I think is fascinating. And the experience in the Aboriginal women in Australia is they just walked home. They were transferred to the hospitals, and they just walked back home again because they weren't going to have their babies in those hospitals miles away from where their communities were. So I think there are some very interesting subtleties around this that we really need to tease out that have relevance for us as well as for countries where maternal mortality is more obviously tragic. And I want to finish the last kind of chunk of this really is around social solutions. And this is actually really quite interesting, I think, in many ways. I'm going to give you a couple of examples. They're not good quality research necessarily, well, one of them is, but by and large, they're observational studies that have not yet been scaled up, but provide very interesting information. The first one is from Bolivia, and this was a Christian Aid project. The intervention really, as you can see, training health workers to adopt the simple premise that women's views and feelings should be at the centre of care. That is all they did. No EMOC, no new facilities, nothing like that. So part of that was that they could kneel for birth, they could have their partners with them, and the traditional midwife came to hospital with them. So nothing clever or fancy. They had maternal mortality in the area prior to the project was 600 per 100,000. In the year after, 2 years after, they had one death in the region. Now, I don't know what the denominator was. It wasn't 100,000. So there may have been 10,000 women, probably less than that. But even so, there was something going on here that was about building that communication, building those relationships, acknowledging what was important to the community made a difference. And it might just have been that the women came to the hospital because they weren't scared of the hospital anymore and got what they needed because they weren't scared. This is the research done by Tony Costello and his colleagues. They've done 3 studies now, one in Nepal, one Bangladesh and one India. And you can see the data here. And again, they just got women talking. All they did is they got women in groups talking to each other with a facilitator about healthcare and what was good and what was bad and what was the local hospital like and what was, what about, did you do this, did you do that? Oh yeah, I tried that. Well, what about it? So this is to do with neonatal mortality primarily, but in the first one, in India, they reduced the neonatal mortality rate by 32%, which is, if you had a drug that did that, how much would you pay for it? In Nepal, they reduced it by 30%. In Bangladesh, there was a difference, but it wasn't significant. And what they hypothesised is, in Bangladesh, they had bigger groups, wider, set apart more widely, and less facilitators, less time. So they're now hypothesising that there's a kind of break-even point, if you like. There's a point beyond which this doesn't work anymore because you're not able to build a community. So it has to be small groups, tightly knit, with good communications between them. So they're kind of rolling that hypothesis out. But I think that's really fascinating. Nothing fancy, just talking. Sri Lanka, slightly different, but different approach in that they've operationalised things at lots of levels. So with the local hospitals, they've improved transport links, they've improved their skilled birth attendants. They've really addressed the issue from a range of levels, and they've decreased their maternal mortality dramatically. But again, what they've said is to know your people, know your area. One of the most important things of what's happened in Sri Lanka is having small groups of professionals who really know their area well and can integrate well with their community. And they've halved the number of maternal deaths as a consequence of that and all the other things they've done. And the final example, Ecuador. This is recently. This is a photograph from the journal article that was the newspaper article that was reporting on it, and you can see the woman standing up. She's got an IV in, but she's standing up. And the infant mortality rate. So they did the same kind of thing as in Bolivia. So they let women they allow women to stand up, and they kind of maximise the local drugs, when I say drugs, local herbs that were used in labour, and who they wanted, and the women wanted with them, including their TBA, or DIA in this case. Infant mortality of 7.8 per thousand, which is less than half the national average after this project had been going for a couple of years. They had 1 unrelated maternal death versus 8 in the previous year. And again, it's not a randomised trial, it could have been chance, but still it's interesting. But actually also, fascinatingly, they reduced the caesarean sections from 18 to 8%. So, we may say, okay, it's a problem because women are not having enough caesareans in some parts of the world, and that's true. But in this case, they both reduced neonatal mortality, maternal mortality, and caesarean section all at once. Now, isn't that something we might want to be interested in learning about and doing something about? And the increased hospital birth, that's the important thing here. These women came to the hospital because they no longer felt marginalised, they no longer felt that they had to pay for their care, they no longer felt they were being forced to have the kind of care they didn't want. And again, this relates back to Andrew's talk about women who choose independent midwives because they are so traumatised by the NHS, and because the NHS will not allow them to do the things they want to do. What this place did is they effectively made the NHS equivalent somewhere those women could go and feel safe and happy. So finally, just to wrap up, what works for who in what circumstances? This is a kind of concept by Ralph Paulson, which I think is a very interesting one. It's not standardised protocols. It's not doing the same thing for everybody. It's about equity, not equality. Doing what's best for the individual, which might not be what's best for everybody as a whole. Might not be what the nice guidelines say. And there's a programme called PPOR that takes that line. Basically, it's about engaging with the local communities, finding out what matters to the local community, finding out what the reasons for mortality are in those communities, doing collaborative action plans, and then making them happen, which seems to be very sensible, and fostering political will. This is a quote I love. It's from Irving Loudon, who's a medical sociologist who looked at maternal mortality between about 1880 and 1950 or something across the world. And as you can see, I'll let you read the quote. My underlining. So, respected midwives who were also trained, licensed and regulated. And one of the reasons women choose TBAs is because they respect them and trust them, and they don't respect and trust the professional staff in the hospital. So, trained, licensed, regulated, respected midwives, close and cordial cooperation. That's not just having a chat every now and again. That's actually getting on really well and trusting and having mutual respect with hospitals, and that led to the best kind of outcome. And again, I think that's relevant in all the countries that we're talking about here, really. So there's no doubt that risk is real. The clinical risk is real, and this is a quote from the RCM. And clearly we're not in this state in the UK at the moment, thank God, but many countries of the world are, and we run a risk of increasing our adverse outcomes if we're not careful. But birth is more than the physical, and I think this quote is really important. So anyone who thinks about it long enough, birth cannot simply be a matter of techniques for getting a baby out of one's body. It involves our relationship to life as a whole, the part we play in the order of things, which is the point being made by those Inuits. In fact, it was the Inuit male elders who were making the point around the meaning of life for the local community. And it seems to me that there's lessons from the maternal mortality agenda that we should be translating back into our agenda here in the UK, and working together across the world to try and find solutions that are not just tick box solutions, but based on principles that matter to us all everywhere across the world. That's doctors and midwives and women and everybody else that helps us in this context, and traditional birth attendants and traditional midwives. So Amina El-Namar, in her research in Egypt, talked about skilled help from the heart, balancing with two paradigms: physical safety and emotional safety, personally tailored evidence, evidence-based practice and loving touch, balanced with emotional safety by being there and being with. This is, as I say, in the context of Egypt, where the maternal mortality rate over time was very high, and this is what mattered to them. And finally, that point, this is a human rights issue, and it's a human rights for us all. It's a human rights for doctors and midwives, as well as women and partners and babies, and it's about time we got it right. Thank you.